Hi everyone, my name is Dr. Trevor Brown, and I'm a neuroscientist with the Neurocare group. In this episode, I'm going to chat with Dr. Jonathan Downar, psychiatrist and associate professor at the University of Toronto, about how his clinic, in having seen thousands of patients over the last decade, has allowed him to conduct research into brain stimulation efficacy, reducing cost, and improving accessibility for patients, and much more. So we hope you get a lot out of that. At Neurocare, we're all about bringing the newest evidence-based treatments to everyday clinicians so we can make these therapies more accessible to more people. A great next step is to sign up for one of our online courses on the Neurocare LMS. Here you can start learning how to apply TMS, neurofeedback, or TDCS in your own clinical practice. This can be followed up by one of our practical workshops, which we hold worldwide. There's a link below. Thanks again, enjoy the video, and maybe see you in one of our live workshops. Hi and welcome to Neurocare Academy. I'm Dr. Trevor Brown and I have the great pleasure of welcoming Dr. Jonathan Downar today, who's a psychiatrist and associate professor at the University of Toronto. Hi, Jonathan.
Trevor, hey, how are you?
Great, thank you. It's a warm welcome to you and wonderful to have you here. It's evening there. You're in Toronto, is that right?
That's right, just outside of the Toronto area. So it's we're heading into the evening time here.
Yeah. I know you work at the University of Toronto, but you've been travelling a lot recently. But at the moment you are there, and I'm in Melbourne, Australia, so a bit of a time difference there. I'm just going to look. It's great that you could join us, and we're going to talk about brain stimulation and all the sort of the fun research that you've been doing. We're going to be talking about, in fact, the clinical and translational research that your clinic has been able to do, because you've seen thousands of patients over the last 10 years prior to the COVID pandemic. It's allowed you to conduct research into, in particular, the efficacy, the cost, and I guess the access to non-invasive brain stimulation for patients in particularly rTMS, so transcranial magnetic stimulation. So that's the main goal of this interview, is to get your views on that and how we can bring it to the people, so to speak, bring it to the patients.
That sounds fantastic. Great. Thanks for inviting me, and thanks for having me on the program.
Yeah, look, it's an honour to have you to be talking to you and getting this information out to everybody. So just for anybody who's listening, tell us a bit about yourself. Where'd you grow up? Where'd you get educated?
Sure. Okay. So I'm a first generation Canadian. My mom and dad are from Europe. They were planning to stay in Canada for a year, but one thing led to another. And so my brother and I were born here and grew up in Canada, in the Toronto area. I've done some studying in Montreal. I've done some studying out in Calgary, and I've done some studying down in the United States. But each time in the career, every time I left Toronto, it seemed to draw you back in. There's a lot of work going on there. And so it seemed circumstances always ended up bringing me back home again to keep working. What could I tell you a little bit about? So when I was younger, I suppose I was always interested in the brain and in neuroscience and so on from a fairly early age. My father works in interventional cardiology. So when I was a kid, we would go over to his lab, and he was studying how electrical rhythms worked in the heart and how they could get stuck in reentrant rhythms going round and round in circles, chasing themselves, and that would lead to problems with the heartbeat. At the time, I wasn't sure I wanted to go into medicine. I thought it would be sort of important to do something different than your dad. So, and now I spend my time tracking down circles of electrical rhythm in the brain and figuring out how those lead to disorders. So I accidentally ended up doing pretty much exactly what my father does, but just in a different organ. So it's a little strange.
It's funny, isn't it? We always pick up more from our parents than we realize at the time.
Yeah, absolutely.
No, fantastic. I just wanted to go over a little bit of the research that you've done. So during your studies and your graduation, etc., you did some early work in 2001 on sensory networks and which areas of the cortex were activated. You used the technique of functional MRI, and all of this related to attentional networks and which aspects of the sensory system were activated during salient activity, novel situations, so the relevant and irrelevant information, and in fact the temporoparietal junction played a large role in that area. What can you tell us about that early work?
Sure, I'd be happy to. So, let's put ourselves back in the mid 1990s, and it was right around the time where it was going from sort of unrespectable to respectable to start thinking about things like consciousness. And so, the consciousness problem was just starting to drift over from philosophy world into neuroscience world. At a time when there were new techniques for imaging the brain using functional MRI, which meant that you didn't have to use the radioactive dyes of PET scans to look at what the brain was up to. So I was entering right around that time, and I was one of the young folks who was interested in studying consciousness in the brain. And so, I had an opportunity in Toronto to do work in the lab of Karen Davis, and she was a pain researcher, but she was very accommodating, and she let me do this work in consciousness. And we kept stumbling across this network this network of areas in the brain that seemed to respond to salient things. So it would respond if you heard a noise that suddenly grabbed your attention, or if you saw some visual thing that grabbed your attention, or if someone tapped you on the leg. And so we studied it in various ways, and we found out that, yes, there was this network of areas that responded to salient things. So subsequently became called the Salience network. And I did my PhD thesis on it and wrote it up. And at the time, it sort of seemed that it didn't have any practical applications. And so working at a hospital for 4 years, you start to see that there's a lot of patients who are going through a lot of difficulties. And so it seemed like it would be a good idea to go off to medical school and try and use some of the advances in neuroscience to try and develop new treatments for things. And at the time, I remember thinking that the Salience network was unlikely to have any practical applications in my lifetime. And so it was time to move on from there. And subsequently, it turned out the Salience network is fairly central to most, if not all, axis 1 psychiatric disorders. So we can't always predict where things are going to end up.
Yeah, exactly. It's ironic, isn't it? And that you're still using that Salience network so much in your current work and our current understanding of psychiatric disorders. Mm-hmm. So then you did a lot of research, but I want to talk about some of the research you did in 2013, 2015, or what was published in 2013, 2015. You began looking at some new stimulation targets. You really got into brain stimulation and the treatment for psychiatric disorders. And what you pioneered, I guess, was rather than looking at only the DLPFC, which is the dorsolateral prefrontal cortex, which is a stimulation target used for treating depression with TMS, you started to look at some different areas, such as the dorsomedial prefrontal cortex, we'll call it the DMPFC, and also the orbitofrontal cortex, the OFC, and then the connectivity between those networks, how they related to psychiatric disorders, but also the safety and tolerability of these, because we know that stimulation of the DLPFC, right or left, it's tolerable, but having a coil right over the eye for the orbitofrontal cortex, that must have been quite confronting to begin with, Jonathan.
Yeah, so we can certainly get to what it feels like to undergo TMS at the time, but let's zoom back a little bit and talk about the whole scenario that we were facing in 2010. So, first of all, imagine I'm coming into the field of psychiatry with this background in neuroanatomy, which seemed like it ought to be terribly useful if you're training as a psychiatry resident. And after a few years of psychiatry residency training, it became quite clear that you could be a great psychiatrist without knowing where anything in the brain happened, because your treatments like medications and therapy, they're not anatomically specific. So you can't make Prozac just go to the left frontal lobe or just go to the right parietal lobe or so on. So it turned out that knowing where things happen in the brain could potentially have been completely useless information, except that right around that time, we were starting to develop anatomically specific interventions. The invasive ones were things like deep brain stimulators that were beginning to be implanted in the brain for depression and other psychiatric conditions like anorexia and so on, and OCD. And then on top of that, we had, fortunately, non-invasive solutions that were being approved in the decade before that. So thanks to a lot of hard work, initially by Tony Barker, who invented transcranial magnetic stimulation, and then later by Mark Hollett and Mark George and Alvaro Pasqualeone, and all the giants on whose shoulders we were standing to do this. I was coming into the field at a time when we had some approved devices that had been proven to treat depression. It's just that, and the hope was that they would be as good as the most effective treatments we had at the time, like ECT and so on, but without the side effects. Unfortunately, at the time, they were underperforming. And so there's often a hype cycle to technology where at first everyone's really excited it's going to do amazing things. And then a few years later, it doesn't live up to all the hype. And so everyone dismisses it and thinks it's terrible. And that's right around the time I was getting a TMS, where the general philosophy on it was that if you asked your average practitioner, they said, "Oh, I've heard of TMS. It's, it's like ECT, except it doesn't work." And so, why are you working on this strange technology? Well, because we knew where things happen in the brain, the idea was that maybe we could start to get the numbers to improve if we could think a little harder about where we were stimulating and maybe try some new areas, maybe even tailor the area where we're stimulating to the individual patient. So the first thing was to go back to the roots and try and figure out what brain areas might be important to things like depression, which at the time was the major indication for treatment. When you're trying to tie the function of a brain area to a specific location, you want to rely on a bunch of different pieces of information. So there's correlation studies like functional MRI and PET studies that you have somebody in the scanner, they're doing some task and you see some areas activate in correlation with their performance of a certain task. Now, correlation isn't the same as causation, so you also need to back that up with causative techniques. And a causative technique could be things like lesion studies. So a person suffers a lesion to some area of the brain, and then that causally either causes the relief of symptoms or creates symptoms. And then there are also stimulation studies. Those are causative. So if you stimulate an area and you relieve a symptom, or you stimulate an area and you generate a symptom, that's also causative evidence. And then the fourth pillar is connectivity. So if you have an area that's all wired up to the retina and not wired up to the motor cortex, it's probably not a motor area. Whereas if you have an area that's wired to your spinal cord and your muscles and not wired to the retina, it's probably not a visual region. It's probably a motor region. So you can often make some inferences about an area from who's talking to it, who are its inputs and who are its outputs, from what happens when you stimulate it, from what happens to people where it's been lesioned, and then finally put that together with correlation of under what circumstances does it activate and so on. And you start to be able to home in on what areas are relevant. So right around this time, we were starting to get rather nice maps coming out of the areas of gray matter that were thinning out in depression. And we were also starting to get some studies coming out describing people who would develop depression after lesions in certain areas of the brain. And interestingly enough, there were also people whose depression was relieved by lesions in certain areas of the brain, or people where lesions, despite being very disabling, would often help people, would often cause people to not be depressed even if they were very disabled. So for example, the dorsolateral cortex was an area where we were stimulating with rTMS with some effect. But some of the areas that were showing the most thinning on gray matter were the dorsomedial prefrontal cortex. And lesions of the dorsomedial prefrontal cortex were leading to depression. And in our hospital, we had a person where the neurosurgical team was treating them for Parkinson's, and instead of turning down the activity in one of their motor areas, because of the electrode being a little out of position, they were turning off the activity in the dorsomedial prefrontal cortex. And every time they did this, the person descended instantly into dysphoria and sadness rather than having their. So we've got lesions of the dorsomedial that were leading to depression. We've got deactivation of the dorsomedial leading to depression, and then we've got these correlations of gray matter thing in this area. So it seemed like a good bet that maybe if we could turn on the dorsomedial prefrontal cortex rather than turn it off, that this could be helpful in depression. And I think at the time we were certainly hoping, let's try this new brain area, the dorsomedial. Maybe it'll be different. Maybe instead of 20% remission, we'll get 80% remission, Nobel Prizes for everybody, remissions for everybody. It'll be fantastic. And that's not what happened. What happened was almost more interesting, was that we tended to see a bimodal distribution. So even though all these patients were diagnosed with depression, when we treated them with dorsomedial, some of them showed nothing whatsoever, really no change whatsoever. And then there were others who had these dramatic improvements, not just in depression, but also in other things like binge eating or things like PTSD symptoms, or in some cases, even OCD symptoms and so on. So we were seeing that this treatment wasn't really just about the depression, because in some people it wasn't helping their depression at all. And in other people, if it was helping their depression, it was also helping them with a lot of other things. And it was around this time that my colleague Amit Etkin over at Stanford and his team started looking at what areas of the brain were thinned out across multiple axis 1 disorders. And there were different areas for all the various axis 1 disorders that were thinned out in the gray matter. But if you looked at the intersection of them all, like imagine a Venn diagram of all the areas of the brain that are thinned out across, depression, PTSD, substance use disorders, OCD, lots of different things. There's a network of areas that popped out, and that network of areas looked very much like the Salience network. And so it made sense that, if you were a depressed person who had a lot of other axis 1 disorders all at the same time, and you stimulated this dorsomedial region, which was part of the Salience network, if it worked, then you didn't just see improvement in the depression, you also saw improvement in all the other, the ADHD, the borderline features, the intrusive thoughts, the PTSD, the binge eating, whatever else happened to be in the picture. And so that was, I guess, where we started coming at this new target, and we saw these interesting things with it. And whenever you have a bimodal distribution of two different groups of people, you start thinking, well, wouldn't it be nice if we could predict who was who, and could we start to use brain imaging to look at who's the right person to do dorsomedial, and maybe who should do dorsolateral, or who should do some other areas. And that kind of work is still going on today. Nolan Williams, who I think you've had on the show earlier, and Connor Liston are doing a study right now where Connor's developed a biomarker that might be useful for predicting who's going to improve on dorsomedial versus dorsolateral. And it's being put to the test right now. So hopefully in a year or two, we'll have some results as to how that's working.
Well, it's amazing how those serendipitous events, like the deep brain stimulation, electrode being in the wrong spot, sort of guides what we do in life. So that's a great anecdote. Thanks for bringing that up, Jonathan. So you started to get really interested in these networks and being able to personalize TMS based on the neural circuitry of different symptoms of axis 1 psychiatric disorders. We mentioned safety and tolerability, so you started to look at that. You saw that it was safe and tolerable, not just in the DLPFC, but in these other areas as well. You looked at, in that time period, some different parameters, such as intermittent theta burst stimulation, and started to get involved or interested in, the fact that you can do this treatment in a short space of time. And you looked at the comparison between iTBS and 10 Hertz, and also DLPFC localization between BMF3 and MRI navigation. So you started to look at the parameters involved in TMS.
That's right, and I think the context here is important. So it's important if you visualize where we were doing this. This was at a major downtown hospital, which was a teaching hospital and a research center, and so it wasn't just a lab; it was also a clinic, and people were coming down here for their treatment. And one of the interesting things about not just being a lab and also being a clinic is, you have a lot of patients coming through. And if you listen carefully, they'll tell you what you ought to be working on, which isn't always the same thing as what you thought you were supposed to be working on. At the time, we thought that the problem with rTMS was the remission rate. And so, we were really doing everything we could with biomarkers and artificial intelligence and machine learning to try and figure out how to boost up the remission rate. And what we started noticing is, after a few years, nobody was really complaining about the remission rate, but they were mostly, the patients were coming in and they were saying, well, the remission rate sounds fine, but why did it take me 9 months to get in to see you? And why are the waiting lists so long? And so we started thinking about that, and we noticed that, the standard treatment protocols were, 38 minutes for the standard FDA approved protocol. And, there were some newer ones out there like Theta Burst stimulation. And I guess we were all thinking, well, if we would repattern the pulses so that they mimic the brain's natural theta rhythms, then it's a 3-minute protocol instead of a 38-minute protocol. And even then we were still thinking, well, maybe this could improve the remission rate. It didn't occur to any of us initially that actually, even if it didn't improve the remission rate, but it was just 3 minutes, it would still be 10 times faster. And if it were 10 times faster, then a lot more patients could come. And we were a free clinic, so anyone was allowed to come. So the problem with being free is that, there's a big lineup. And so we moved to Theta Burst because we didn't like the size of the lineup, and we really just wanted more people to come in and be able to get treated without waiting around so long. And we found that, sure enough, Theta Burst, we were hoping it would be better. It turned out to not really have a higher remission rate or a faster onset, but it was allowing us to treat a lot more people. So each one of our machines could have shorter appointments, and many more people per day could come through. And so we decided this might actually be quite a useful thing, because one of the issues with TMS is it was working very well for people where medications had failed and therapies had failed, but access was certainly an issue. So we thought, let's just work on the access problem. And so we had a kind of a dual study where, on the one hand, we were scanning people, and we planned to use the scans and try to do some machine learning to predict who was going to respond and who wasn't going to respond. But as a backup plan, we said, well, even if that part doesn't work, let's have half the people do 3-minute treatments and half the people do 38-minute treatments. And perhaps as a side effect of this, we'll be able to see whether the 3-minute ones are as good as the 38-minute ones. So we teamed up with my colleague, Dan Bloomberger and Jeff Daskalakis at the hospital down the street at Center for Addiction and Mental Health, and my other colleague, Fidel Vila Rodriguez, over at University of British Columbia. And so we had this group of people, and we spent 5 years treating about 414 patients in Canada. 5 years to do the study, and another 5.5 years, I suppose, to come up with the acronym, the Theta Burst versus High Frequency rTMS Effectiveness Evaluation in Depression, or the 3D study. And the happy outcome of this was that the trajectories improved. When we plotted out, the little lines showing people's scores of improvement over the 6 weeks of treatment, the line for the 3-minute treatments was exactly on top of the line for the 38-minute treatments. So they were non-inferior, and they were doing just as well. And the FDA was kind enough to look at this data and grant FDA approval about 4 months later for the 3-minute treatments. So it got very quick uptake in the US, and surprisingly quickly around the world, people started moving to the 3-minute treatments. As far as we can tell, I mean, there have been many, many thousands, possibly over 100,000 people who've received the treatments now. So it was one of those nice translational findings where maybe we didn't outsmart the problem, maybe we didn't do machine learning and so on, but there were probably tens or hundreds of thousands of people who were getting the treatment who might not have had a chance to get in there if we hadn't just made them faster. And so I guess that's worthwhile keeping an eye on. In translational medicine, sometimes you don't necessarily have to outsmart the problem. It's okay to improve the logistical feasibility of things, because if what you're after is trying to make sure that more people get to remission. And so if you're prepared to be broad-based about that, and as scientists, we always want to outsmart the problem, but sometimes it's okay in medicine to outdumb the problem and just keep things really simple. And so simplifying the treatment down to 5 to 3 minutes was somewhat scientifically interesting, but the main thing was it allowed a lot more people to benefit from the treatment.
Yeah, and I guess by this time you're through this work of the FDA approval and the broad contacts that you made within the field, your published literature, the amount of patients you were treating, you became somewhat of a known expert in the field, and were able to then help with the Canadian guidelines in TMS around that time as well. What the acronym is the CANMAT paper, and it looked at then using TMS as a first-line treatment after one failed antidepressant medication treatment, which was really a great step forward for accessibility for people.
Yeah, so it's an interesting question that's been a bit of a moving target. So as TMS has progressed, and that is one of the exciting things. It's been a very fast moving. So the TMS we had when I started in 2010 was better than what we had before that, but not as good as the TMS we had in 2015, which was not as good as the TMS we had in 2018, which is not as good as the TMS we have today. So it's really, really fast moving, which is encouraging if you're a patient or the caregiver to a patient. So these guidelines in 2016 were sort of trying to encapsulate the best available evidence of the day. I don't want to spend too much time on what they said, because we are 6 years later now. But it did raise the question of at what point does it make sense to offer rTMS. And initially, when the FDA approved the treatment in the United States, the approval was for people who'd failed at least one medication trial. And now we're seeing that, in fact, if you have people who failed 2 or 3 or 4 medication trials, the remission rates are several times higher if you do rTMS than if you try medication number 3, medication number 4, medication number 5, and so on. The bigger question would be, and we do get patients who come in and say, well, I haven't tried any medications yet. I really don't want to have to try medication. I'd rather just do the rTMS. And could I just do that? Would that be all right? And we've now got, Andy Luchter and Linda Carpenter and some others have done a nice meta-analysis of the literature to show that, in fact, there's pretty good evidence that even for people who haven't tried any medication yet, rTMS is quite effective. And the effectiveness does seem to go down somewhat for people who've been ill longer or people who've tried more medications. But it looks like the main reasons for treating people after one or more medication trial may be less about what works and more about just the scarcity of the treatment and how there's only so much to go around. And so if we could solve the scarcity problem, there's no reason why people should have to try a bunch of medications before they go to medication. If they want to try medications, if that fits their lifestyle best because of the convenience, that's great. But then if it turns out that they're willing to go through the extra, logistics of going through rTMS treatment, then if we could somehow make enough rTMS to go around for everybody, then it seems like that would be an effective thing to do. And I think that's a key point, is that the idea of rTMS requiring a few failed medication trials is less about what works and more about just the limited access of the treatment. So in a perfect world where, if there was an rTMS machine in every pharmacy, then, and people who walked into the office and said, I'd rather just start with rTMS, from a, does it work point of view, from a science point of view, I think there's fairly good evidence now that that's not a bad idea.
Yeah, look, and that's one of your, I guess, mandates and what you've been working on with the university, and a passion for you. So we might come back to that just when we finish talking about the personalization and some of the other research you've gone through. But the cost, the efficacy, and obviously accessibility is a key point. And having one in every pharmacy down the road would just be the ideal situation, wouldn't it? And it's interesting because we get a lot of questions about whether TMS can be used as a first-line treatment, and whether you need to have failed antidepressant medications beforehand. So having heard that from you, that you have tried it as a first-line treatment and that it is as effective as it would be as a in a treatment-resistant population, well, I think that's really interesting because it's a question we get a lot. So moving on to 2019 to 2022, just very quickly, you continued to look at the personalised approach to rTMS and the targeting of different areas, the orbitofrontal cortex, the DMPFC, and using symptoms to select which region. Can you tell us a little bit about how you found these biomarkers based on symptomology, and then whether that would drive your personalization, or should we just stimulate all of them?
Okay, so that's an interesting question. Let's start off with the background on this. So, as through the course of the 2010s, we were looking at all the various areas that seem to be linked to emotion regulation, and the dorsolateral prefrontal was one of them, and that's the standard TMS target. The dorsomedial also seemed to be effective, and that's now been FDA approved as well. So at least one of the manufacturers has now got a device that initially was approved for OCD and does stimulation. And now they've received approval to use that same dorsomedial coil in treating depression. It seems to work just as well as the dorsolateral site. We also got very interested in a third area called the orbitofrontal cortex, which Professor Edmund Rolls from the UK had been studying in primates and humans for a long time, linking it to a thing called the non-reward pathway of the brain. Now, most people have heard that the brain has a pleasure circuit or a reward circuit, and that it can get hijacked in substance abuse and so on. But basically, a circuit in the brain that creates, or that sort of is there to represent positive incentives and figure out what we should be working towards and how we might get rewards. If that was the only thing steering our frontal lobes, we'd be manic because we'd have no system for the downsides of life. So you need a system for spotting possible upsides and being motivated to go and chase them down. But you also need a non-reward system that is the complement of that to spot potential penalties or problems or negative incentives and feel motivated to avoid those. If you don't avoid those, then effectively you're manic. So one of the interesting theories that Professor Rolls came up with was the idea that what if the non-reward circuit of the brain got stuck in a feedback loop and was just feeding back into itself. They do inhibit one another. So the non-reward circuit seems to inhibit the reward circuit. So he described what he came up with a theory he called as the non-reward attractor theory of depression. In other words, that this non-reward circuit would get stuck in an attractor state, basically a feedback loop. A little bit like, say, ventricular tachycardia, when the heart gets stuck in a feedback loop of electrical activity going round and round in a circle. So if the brain were to do the same thing, then the person's thoughts would come to be dominated entirely by negative incentives and downsides and things that had gone wrong or might go wrong or would go wrong. And it would be very difficult to generate any positive incentives or to enjoy anything or to think of any positive things or to be positively motivated to do anything. You'd just be entirely motivated by negative motivations. That would be sort of the reciprocal of mania or depression. What I really liked about the non-reward attractor theory of depression that Professor Rolls came up with is that patients really resonate. It was the first time that the neuroscience really matched up nicely with the patient's lived experience. So you'd have patients say, well, I've been told I have a chemical imbalance and my serotonin is off, and that didn't make all like that. I couldn't really tell if my serotonin was off. But when you tell me that my brain's stuck in a feedback loop and that there's a circuit in my brain that's supposed to spot the downsides of life, that's exactly what happens. There could be 99 things that are going well in my life, but my brain will find the one thing that's wrong and it'll just go round and round and round on it in circles. And it's like I can't break out of it. So the idea was, what if we could, stimulate that brain region in the orbitofrontal cortex, not with excitatory stimulation to boost it up, but could we use low frequency stimulation, which seems to have an inhibitory effect, and try and break up the loop so that we would just interrupt it. And if we interrupted the loop, maybe the reward circuit would come back on and the person would be able to enjoy things again and experience pleasure and emerge from the depression. Now, since we already had two perfectly good treatments, we wouldn't start with this. So we were starting people with dorsolateral and dorsomedial. But in our clinic, we had, we definitely had people who tried dorsolateral and it didn't work. And then we tried dorsomedial and that didn't work either. And they still wanted to come, they were really quite motivated. They wanted to come back and do more. And so we started offering some of them orbitofrontal because we knew it could be done safely, because we'd seen in OCD that a group in Europe had tried this in OCD, and they would use PET scans to show that it was indeed suppressing the activity in the intended area and that it was improving their OCD symptoms. And if you read the fine print, it also seemed to be improving their depression symptoms. So there was a precedent to maybe try this in people who didn't have OCD. And what we noticed was that it seemed to actually work. Not only did it work for some people, and not only did the reward function come back, so people were coming in and they're saying, I'm not obsessing about negative stuff as much, and I'm able to enjoy things again. And there was actually even a separation. Sometimes you'd have particularly ill patients who had both eating disorders and depression and suicidality and substance abuse and lots of other things. And when we would do dorsomedial stimulation for them, they would say, well, you told me this would help my impulse control. And that is actually true. Like, I've noticed I don't have binge eating as much and I don't purge as much, and I don't impulsively blurt things out, and I feel more in control, but I still obsess about suicide every day, just like I have for 20 years. And then when you bring them in, 3 months later, a spot would open up and I'd bring them back in for orbitofrontal, and we would do the orbitofrontal stimulation. They said, this was different. This was a really different effect. I didn't notice anything at first. And then one day it was the weekend and I was playing with my nephew and niece and I realized I was enjoying it. And then I thought about it and I realized I hadn't had any suicidal thoughts that day. And I thought about it some more. I realized I hadn't had any suicidal thoughts the day before that either. Like, I hadn't had any suicidal thoughts all weekend. And this is the first time in 20 years that I've had a weekend with no suicidal thoughts. So something is definitely different. And then they would say, but I think the first one is wearing off because I'm starting to binge and purge again. So can I go back and have that one? So you really saw these separations between the two. And we started to get the hang of looking at people's symptoms and finding that there were some people with depression who also had a lot of sort of difficulty regulating their thoughts and their emotions, and they seem to do quite well with dorsomedial, which makes sense because there was other studies showing that even if you're not depressed and you do dorsomedial as part of a research study, so if you're a graduate student or you're somebody who's just, euthymic, if you do dorsomedial, you get measurably better at impulse control for a little while after the stimulation. So it wasn't really treating people's mood. It was really enhancing their ability to self-regulate their thoughts and behaviors and emotions. But not all depressed people have that problem. Some people are really good at regulating their emotions and they're quite emotionally stable. It's just they're stable in a negative state. And so they will say that they're very obsessive, that they really kind of worry about, they sweat the details all the time. They're much better at picking up on the negatives of life than the positives of life, and they'll tend to get stuck on them and just go round and round and round on them. And those folks then tended to do better on the orbitofrontal. So what we were seeing in clinic with these different, so we would say, okay, they're all coming in with depression, but if they have depression plus a bunch of impulse control things, they seem to do better on dorsomedial. If they have depression with a conspicuous absence of any impulse control stuff, or any difficulty regulating their thoughts and emotions, then they seem to do better on orbitofrontal. Now, around that time, Connor Liston's group out of New York was looking at biomarkers. So let's come back to the biomarkers question. So rather than just sort of look at people's history and symptoms, he was looking at large samples of people with depression, by which I mean hundreds or thousands of people with depression, and trying to figure out whether there might be little subtypes of them based on their brain activity. So by looking at, I think, about 258 different brain areas and how they connected to each other, building a big cross-correlation matrix of all the communication or the correlations in signal between all these 258 areas with each other, it did look like he was able to sort them into little fingerprints or biotypes of collections of patients, 4 different types, each one. And they could be organized into dimensions. So one dimension was whether they had a lot of anhedonia or not, and the other one was whether they had a lot of anxiety or not. So we'd have these. So there was an anxiety and sleep disturbance on one axis, and there was motivation and anhedonia on the other. And so although they were all depressed, some of them had more of a load of one symptom versus the other. So there were these 4 types. And in the course of studying this, they got interested in whether this might have practical applications. So it's one thing to say, oh, we've scanned 2,000, we've looked at 2,000 scans and they fall into these 4 groups, but it's more compelling if you can suggest that those 4 groups have treatment implications. So Connor contacted us and he knew we had a lot of scans. So we gave him our scans of our dorsomedial patients. And I think I remember telling you the dorsomedial patients were interesting because they either did really well or not, or they didn't do well at all. Like just nothing happened. And sure enough, he looked and he found that types 2 and 4, or types 1 and 3 did rather well with dorsomedial stimulation. They had a lot more improvement, and types 2 and 4 really didn't show very much improvement at all. But what was interesting is of the 2 types that didn't respond well to dorsomedial, when you went back to the brain activity, one of those types had a big abnormality of activity, of connectivity in the right orbitofrontal cortex, which is exactly the other spot that we were treating. So it was interesting to suggest that these biotypes might actually line up with what we've been seeing in the clinic, that some people were better with dorsomedial, some people were better with orbitofrontal, and there seem to be symptom differences between them as well as differences in brain activity. So then finally you come to what do we do with that information? And one approach to that is, well, let's scan everybody before we treat them, and then we will apply our machine learning algorithm to the scans, and we will decide whether they should be a dorsomedial person or the orbitofrontal person. And that's certainly one approach, and that might turn out to be the right way to go. Now, patients, of course, they'll often come in and ask simple but important questions. So patients would come in and say, well, I was thinking about being in your study, and then I came home and I started thinking some more. I'm like, could I just have both and not do the scan? Could you just give me both of them? And perfectly valid question. What would happen if you just gave everybody both? I mean, part of the point of getting it from 38 minutes down to 3 minutes is that you could potentially treat more than one brain area. So once again, this is scientists having to resist their temptation to outsmart the problem and having to be okay with, make their peace with the idea of just outdumbing the problem rather than outsmarting the problem, saying, well, we won't try and personalize it. We'll just give everybody both. In medicine, that's sometimes the right strategy. So for example, with HIV, part of the reason we're making progress on HIV is that we figured out how to make antiretrovirals more accessible, less expensive, and put more than one of them in a pill. So the way forward on HIV was not to, take blood samples and do machine learning and try and predict how the virus would evolve and just chase it down with one med and then another med and then another med. It turned out to be simpler to just outdumb the problem and just focus on making the medications cheap and convenient and easy to use and accessible, and then put more than one of them in a single pill and make that pill something that didn't have to be refrigerated or taken 4 times a day with food and so on and so forth, just generally make it more user-friendly. So there's valid traditions in medicine of both. There's valid traditions of beating diseases by using personalized treatments, as we're starting to see more and more in things like cancer. And there's also, great histories in medicine of having success by not trying to personalize things, but just by making things more convenient, more accessible, and just putting lots of different things into it. Like making a composite treatment that's composed of many things and making sure those things are not really expensive and hard to get, but are affordable and really easy to get. And it's not either or. So with TMS, one of the interesting things we're going to find out over the next few years is, do we need to personalize for everybody? Or should we be outsmarting the problem, or should we be outdumbing the problem? Or should we be outdumbing it for some people and outsmarting it for others? So this is what we are hopefully going to learn over the next few years.
Well, great answer. And I guess with the same goal of increasing those response and remission rates, is it personalization, or is it outdumbing the problem, as you say, and making it more accessible and just, giving TMS to those 3 locations, DLPFC, DMPFC, OFC, and I guess the next question would be, is that going to be, if we did try that, are there any push-pull effects? Is there any negatives? Negative effect on the OFC stimulation or the OFC results if we then go back and do DMPFC, or vice versa? Do you have any information on that, or is that just so far down the track?
That's an interesting one. So the question, so you wouldn't want to be in a situation where you stimulate one area and push the system one way, and then stimulate the other area and just push it all the way back again to where you started, and you haven't really accomplished anything. Anecdotally, that doesn't seem to be the case. Now, in terms of actual experimental studies, I think the studies are still to be done. So technically, we are going to have to sit down and trials are big and expensive and take a long time to do properly. But at some point there will be a point of looking at just stimulating a single brain area versus stimulating multiple brain areas, and and picking that area based on some sort of personalization algorithm versus just using the same area for everybody and maybe fine tuning the location. So people are trying there's different types of personalization that are going on out there. So one approach to personalization is to look at the idea that maybe this category called depression is actually a lot of different things at the brain level. And so what we really need to do is do something akin to blood types with people, or categories or dimensions, and figure out what flavor of depression does this person have, and then try like orbitofrontal for this person, dorsomedial for that person, and so on. Another approach, which is part of the Stanford SAINT approach, which I think you would have heard a lot from my friend and colleague Nolan Williams, who from Stanford. A key ingredient in his approach is they're generally using the dorsolateral prefrontal cortex, but they're taking into account the fact that dorsolateral target is not in exactly the same place in the frontal lobes for everybody. So if you have a scan and you have a map of where the network is that you're trying to target, that network might be 2 centimeters up over in this person, or it might be 2 centimeters further forward in that person. And there is some evidence from Robin Cash and some of his colleagues in Australia that if you're more than a centimeter or two off, that the outcomes don't look quite as good. So you may not have to be down to the millimeter, but certainly you want to be fairly close. And if you're more than a centimeter or two off, then there's a higher chance it may not work. So you might personalize by just choosing a brain area based on the person's symptoms, or you might not do that. And you might also personalize just saying, okay, dorsolateral is a big place, and we need to personalize exactly which exact site of dorsolateral we're going to be stimulating, and that's different from person to person. And you will hear Nolan, it's not my sort of tell, but Nolan will certainly describe patients he's seen where you stimulate them at the standard out of the box target and you don't get any effect, and then you stimulate them using the personalized target and they do get an effect. And then they go to some other clinic and they go back to the standardized target and it doesn't work. And then Nolan sends them the little swim cap with the dot on it from their study, and they stay at the same other clinic and they get it, and it does work. And so, so it might be quite important, at least for some group of people, to you're not going to be close enough unless you do some personalization there. So that's another approach to personalization you could consider. And then, of course, you got my colleague Martin Arens, who's got an interesting idea that if you're over the right spot, at least for dorsolateral, he's got some evidence that just as there are some areas of the brain where your thumb might move if you stimulate there, if you're over a part of the dorsolateral prefrontal cortex that's tapping into the limbic system, at least the theory is that you're going to be stimulating it, and it's going to be suppressing the activity in the amygdala, which will then go down to the brainstem and down through the vagus nerve. And so what he's been noticing since about 2015 is that if you're in the right spot, then as you stimulate away in the dorsolateral, the person will get their heart rate will actually slow down by a few beats for a few seconds. Not, usually not to the point they pass out, but if you're in the right spot, then you can drop the heart rate and as you stimulate over and over again, the heart rate drops each time. And so the question is, what if you're in a place where they don't have great access to fMRI? If you're not in a country or in a setting or in a scenario where they have, the expertise to do that, could we at least get some people there personalizing it just by trying different spots on the side of the head until you get the part that is best at dropping the heart rate? And would that be, good enough for some people? And what I like about that approach is that, we probably do want to personalize, but as we personalize, we do have to keep an eye on scalability. We do have to keep an eye on access, because depression is not a rare disease. A lot of people with depression. And if we needed a detailed MRI scan for every single person, then, that's going to be a really long lineup. And for some people, it's going to be a deal breaker. So, we want to develop these techniques, but we also want to keep an eye on whether there are ways to do them in a simple, scalable way, at least for, some proportion of people. Because if we can do that, then the number of remissions that comes out of all our work is higher, and we stand a better chance of improving the numbers. That's really important, because if you look at the prevalence of depression, or you look at the prevalence of suicidal behavior and that sort of thing, There really hasn't been much improvement since the 1980s. In fact, in some places, it seems to have gotten worse. So, in particular, among adolescents, the rate of suicidal thoughts and the rate of parasuicidal behaviors has been going up and up in the last few years. And this is despite the fact that there's way less stigma around mental illness now than there was decades ago. It's despite the fact that there's way more people taking antidepressants, and despite the fact that it's way more, on trend for people to go and do mindfulness meditation and all the other preventative stuff. So despite the fact that we've been throwing everything we can, more and more of our conventional treatments at the problem, the prevalence of some things like hepatitis C and so on has been coming down, but the prevalence of depression has not been coming down. Depression, the prevalence of suicidal behaviors has not been coming down. So we're going to need new stuff, and that new stuff can't be just things that 1 or 2% of the population has access to. It needs to be something that everyone has access to. But if we can do that, if we can figure it out, then hopefully within our lifetimes we'll be able to talk about depression the way we talk about other disorders that were very, very common back in the day, and that we were able to find effective treatments for, and nowadays they're rare. So I think that would be the goal, that all of the different folks of us around the world who are working on this, what we're all would love to see within our lifetimes is measurable decreases in the prevalence of depression and anxiety and other psych disorders, thanks to a new generation of treatments, of which rTMS would be one. Not the only one, but one.
Yeah, and you mentioned suicidality there, and you did some research having a look at the difference between 10 hertz and iTBS and whether they both decrease the suicidality aspects of I think it was the HDRS 17, and you found that suicidality features decreased around 43% on both. So iTBS was effective for decreasing suicidality. So it looks like all these things that you've mentioned, your breadth of knowledge is amazing. Thanks for the detail in your answers. Is that where you're moving in your own research now? Is that your current goal? And you mentioned then is bringing this to a larger population. We need newer treatments. It hasn't changed a lot over the last 20 years. Depression isn't coming down, it's going up after the COVID pandemic. These new treatments, we need to make them accessible. Is that what you're looking at?
Yeah, so I think, again, we have to keep listening to the patients and what they're telling us about the treatment. And, it's been very exciting in TMS to see the progress we made on some things. So, the earliest TMS studies were seeing remission rates of sometimes only 10 or 15%. But then they're often only doing 5 or 10 or 15 sessions. And today we know that, the average number of people usually need 30 or 40 sessions, and that there's some people who need 50, some people who need 60 or 70 or 80 or more. And that if you're willing to just give them all those sessions, they will actually get a remission eventually. So we've learned how to do more sessions. We've made the sessions 10 times faster, so more people can come in. And then we've made the courses, as you heard from Nolan, it turns out you don't have to wait and do the treatment just once a day. It looks like you can do it once per hour. So in Australia, Paul Fitzgerald's group and Leo Chen and some other folks have been able to look at doing 3 times a day, which other places call the Australian method of doing, a session and then an hour later doing another session, then an hour later doing another session, or at least with some sort of interval between them to try and speed things up so you can get through all your sessions more quickly. And then there's the Stanford method, in which people are doing 10 sessions a day, and then other variants out there where, in Toronto, we've collected a lot of data on people doing 8 sessions a day. And in Belgium, there's 5 sessions. So people are using all kinds of different numbers of sessions per day. So, the remission rate's getting quite good. If you're willing to do all those sessions, and if you're willing to throw in MRI guidance and so on, the most recent SAINT trial is reporting remission rates from out of Stanford. Nolan's group has been generating a lot of excitement because they're reporting, depending on how you measure it, remission rates well above 50%, getting up into, sometimes 70%, and in some of the earlier papers higher than that. So high remission rates. The other thing is, even if the remission rates don't go up, the idea that TMS can potentially get people to show full effect in 4 or 5 days or even 10 days is pretty exciting, because we're used to depression being something that takes weeks or months to get better. And if it turned out that we just do the sessions more often, well, that was easy. And all of a sudden you've got a treatment that's working in 4 or 5 days, and that would make it really interesting for patients who are on inpatient wards in hospitals, or patients who are in the emergency room. So when we talk about folks who are suicidal, could we get the suicidality to improve? And again, Nolan's group looks like we've seen suicidality improve with rTMS, and by doing many sessions per day, Nolan has been able to demonstrate that, in fact, the suicidality can maybe be improved very quickly within, even though the depression's not all gone within a day or two, the suicidality may be down quite a lot within the first day or two. And so that could be, very, very compelling for people as a crisis intervention. So what's left? We've got faster treatments. And the side effects is the other thing. So one of the things people often, I've certainly had patients who come in and say the thing they love most about rTMS is that they don't have weight gain, sexual side effects, sleep disturbance, all the other things that people complain about with medications. The all causes discontinuation rate in clinical trials from a medication due to side effects is usually around 25% of people leaving the trial early because there's a side effect that's bothering them. In the real world, it may be higher than 25%, but in clinical studies seems to be around 25. rTMS, it's several times lower than that. Quit rate, depending on the trial, some it's more like sort of in the 5 to 10% range, and often that's logistics. So if you can sort the logistics out, then the convenience factor. The one thing people don't love about rTMS is that medications, whether you love them or hate them, they're very convenient. That's usually just if I can get the person to take 5 seconds out of their day and just keep a reservoir of medications next to their toothbrush, then just before they go to bed or when they wake up in the morning, they can take a medication. It's not asking them to disrupt their daily routine very much. The more you ask someone to disrupt or diverge from their daily routine, the less likely the treatment is to stick. And so one advantage of medications, to this day, is that they have a very high convenience factor. And so they may be the preferred option for people who just have really complicated, busy lives and say, look, what I care about most is not remission rate. You'll get patients who say, as much as I'd love a high remission rate, what I really need now is something that will give me time to drive my kids to school and deal with my job and look after my ailing grandmother and all these other things. So they need convenience. And other folks will say, well, no, actually, this is fine. I can do TMS. I can find time out of my day to come in and get the treatments done. But so the things still to work on, at least according to the patients, would be, at least in some countries, the access is a tricky problem. I would say in most places, once people hear about TMS, even if they hear about it on the news, it can be difficult to access. Australia, as I understand, is now incorporating it into the public system, which is really encouraging to hear. Canada has incorporated in some of its regions. Some European countries like Holland have begun to incorporate it. In the United States, it's now available on most insurance plans and in all 50 states and so on. So the access is gradually improving around the world. But it could stand to be better. I'd say of all the people with depression, we're pretty sure that even in the places in the world that have the best access to rTMS, fewer than 2% of people with depression are getting access to non-invasive brain stimulation. So that number is going to have to go up. It's great if we have an 80% remission rate, but if that's, that could reduce the prevalence of TMS, but not if it's only reaching 1% of the population who needs it. If it's reaching 50% or 80% of the population who needs it, well, now we're getting somewhere. Now we could measure a drop in the prevalence and say, oh, great, that was work we did. That was, your science at work finally. So that's what we want to be working towards. In some places, access is about cost, so it might be about reducing costs. And in some places, it's less about cost and it's more just about generally making it more available to people, making it where the devices can go to. Is there a way we could get the devices to the people instead of forcing the people to come to the devices? So those are the kind of the things we have to work at. So it's interesting where we get to a point where a lot of the neuroscience has been done. There's still neuroscience to be done around biomarkers and prediction and around acceleration and the optimal patterns and the optimal personalization and the location of the treatment. So certainly we're not going to run out of science to do. There's lots of science still to be done. But there's also a point where, you stop writing at the bottom of your papers, further research is required. And you say, well, actually further research is not required. Like we're going to do further research to make it better. But at this point, what's really required is to get the thing out there. This is 2022. So in Toronto, it was exactly 100 years ago that insulin was developed by Banting and Best's discovery, or at least their development of insulin in 1922. Is an interesting. Well, when Banting and Best developed insulin, they didn't say, "Oh, great, let's go write another grant." It was time to get. There was certainly more work to be done to make insulin more manufacturable and more tolerable and more accessible. But at that point, a second thing opens up. Yes, more research needs to be done, but if all we do is research and we don't focus on access and cost and convenience, then the insulin isn't going to get out to people who need it. So there was both further research is something we're going to do, but it's also what's required is to now work on improving access and cost and convenience. And I think that, if we've got a treatment that works for depression within days rather than months, and if we've got a remission rate that's somewhere above 50%, maybe above 70%, and if the side effect profile is really low, then it's not that further research is required. It's further research is something we should do, but what is required is to now figure out how to get this out to everybody who needs it. And that's not all necessarily science work. That is to some degree systems engineering. That's engineering work, and that's hardware development, and that's updating the way in which services and treatments are delivered, updating the ways in which TMS treatments are paid for by the system, public or private or whatever the country has. And so it's updating a lot of things, but they may not be brain things. They may be how we build the device things, or how we pay for the treatment things, or how the healthcare system is organized things, those sorts of things. And although, they don't necessarily fall into the category of neuroscience, they're still really useful and they're still really important. So I think we all have a role to play to now get this treatment out to the people who need it.
Yeah, and also educating the therapists, the clinicians about delivering it, and are the clinicians required? A lot of the cost goes into educating these clinicians and the clinicians' time as well. So that's something that's really important. And so, look, Canada is moving forward very, very fast, and is really a beacon for the rest of the world in TMS and non-invasive brain stimulation. So thank you very much for all the work that you're doing. Your global perspective on non-invasive brain stimulation gives us a real great idea about the future of neuromodulation, what needs to be done, where we are at the moment. And any final words on the future of neuromodulation? I know you have to leave soon. So just very quickly, what do you think in the next 5-10 years?
Absolutely. So let's look at let's look at why I'm actually really excited to be in this field, and why I think anyone as a clinician can be really excited about this field. They talk about the 1950s through the 1970s as a sort of golden age of psychopharmacology. So it was a time when we went from not having antipsychotics and antidepressants and things like that to suddenly stumbling across a whole bunch of different compounds and classes of medications that were helpful. So there's this golden age with a lot of progress. And then, there's been more progress recently in areas like psychedelics and so on that, we're not talking about today, but for a long time, things were stalled there. The problem around molecules is that, once you've discovered a molecule, that's it. Like you can't, it's not like speech recognition where you can keep fiddling, or voice recognition or face recognition where you can keep twiddling with it and gradually making it better. Once you've discovered the molecule, you can formulate it differently and so on, but that's fundamentally it. Moore's law describes, computers and how computer chips and transistors gets faster and cheaper. You can pack more transistors on a chip. And so computers have gotten faster and cheaper and better in a sort of logarithmic way over the last few decades. If you spell the word Moore backwards, you get Eroom, and there is an Eroom's law, of which somebody jokingly described, but it very accurately also describes a logarithmic function for the cost of developing new medications in medicine. And Eroom's law is unfortunately, it's a logarithm pointing the opposite way of the one for computers. So computers get logarithmically faster over time, or exponentially faster over time, and then it gets exponentially more expensive over time to find one more drug. There's different theories on why that is. One of them is sort of the Easter egg, theory that, once you found most of the Easter eggs, you have to search a lot harder to find the last few Easter eggs in the backyard. And so, there's other possible ideas behind it. But interventions like TMS and so on, they're still on Moore's law. So if you look at TMS and you look at other, the devices are getting more capable. The protocols and the patterns we run are getting better. So, you can go in and make it 10 times faster per session. You can go in and make it 10 times faster per course. You can end up, coming up with better patterns and personalization and so on. And then the hardware can be made less expensive and more accessible and so on. So there's all these major gains. We can make it 10 times faster to this, 10 times bigger to that, and so on. So I think just the macroeconomics of psychiatry are funny in that they suggest that over the next, 30, 40 years, it's not that there won't be any new meds, because there certainly will, but it's going to be harder and harder, and it's going to be more and more expensive to find them. And so, the cost of when they reach the system, maybe higher and higher, and it may be fewer and fewer people who can afford to access them. Whereas interventions are still on the happier law, on Moore's law, where we can expect rTMS in the future to be faster and better and cheaper than it is, and we can expect that. So that's one. We can also expect that there will be other ways of doing stimulation. So there are up and coming non-invasive forms of brain stimulation, like transcranial direct stimulation, or more broadly, transcranial electrical stimulation. People are looking at permanent magnet type of stimulation. People are looking at very mild electromagnetic fields, like pulse electromagnetic. So people are now looking at focused ultrasound. So mild ultrasonic beams, it might be possible to sort of jiggle the neurons enough that they fire in a non-invasive way. So there's more and more techniques for stimulating the brain that are coming out. And so it'll be interesting to see which ones find a niche for themselves. And then on the invasive side, if you're able to, if you have got a very severe case, or let's say a person who gets better, but they relapse quickly, so it might be better for them to have a pacemaker type thing implanted. We're getting better and better at the hardware and at the processes of getting little pacemaker-like devices implanted into specific circuits in the brain. We're getting better at knowing what those circuits are. We're even starting to come up with techniques for monitoring the brain activity. And so when it starts to go the wrong way, just like an implanted cardiac defibrillator will notice when your heart's going into a rhythm it shouldn't be in and will reset it. These devices will notice when your brain's starting to sort of fall down the rabbit hole of an obsessive or ruminative thought, and can just give it a little jiggle, a few little pulses to sort of reset it so that you don't get stuck down there. So these are all interesting things that are happening. So I think the future involves our existing techniques becoming more accessible and less expensive and easier to use. I think it involves us having a much wider toolbox of invasive and non-invasive options that are going to help. And the last really exciting thing is indications. So unlike with medications, remember when we do a stimulation, we can usually pick which network in the brain we're stimulating, or which target in the brain we're stimulating. And some fantastic work out of Harvard recently, Mike Fox's group and Sean Siddiqui, have been very active in, I mentioned it earlier on, using things like lesions, patients with lesions to figure out, okay, well, which brain areas do lesions cause depression? Which brain areas do lesions relieve depression? Well, you can do the same trick with addictions. You can do the same trick with Alzheimer's and Parkinson's and OCD and lots of other things. And that work's all been really just racing into the literature over the last 3 or 4 years as these groups work very hard to do this. So we're starting to develop target networks for things that are tough, like things like Alzheimer's, things like Parkinson's, and things like addiction. So I think one of the big things we're going to notice is that if we can get a lot of machines out there, not only will they help with depression and suicidality, but it turns out if you slide the stimulator over a few centimeters backwards onto a different area in the parietal lobe, there was a positive trial that came out of Alzheimer's for depression just a few weeks back. And there's some others that are nearing publication. So, and I believe Paul Fitzgerald's group in Australia also has a trial underway in Alzheimer's. So, things that have been tough to treat up until now, we think there's going to be brain stimulation intervention options for them. So keep an eye on that, because not only are we going to see brain stimulation being faster and cheaper and more accessible, not only are we going to see it, reaching more people, but I think we're also going to see a lot more indications out there. So it's something to keep an eye on. And I think, I won't say all, but I think a very big chunk of the next generation of treatments that we see over the next few decades, we're going to see some molecules, but we're going to see a lot of interventions. And so keep an eye on interventions and try and stay abreast of them, because they evolve very quickly. What you might have learned about TMS 10 years ago, it's better now. And it can do more things now, and it can be helpful in a wider range of conditions. So important to keep up with the literature and see what's out there. But really good news for anybody who's suffering from a brain disorder, that their help is on the way. And I think the neuroscience is finally starting to pay off in terms of new treatments that are going to help a lot of people.
Yeah, I mean, the focality of brain stimulation is really something that opens a lot of doors for different indications, like you say. So what an interesting time to be involved in neuroscience. And I hope this inspires other people to, to get into the field, and the younger generation to continue pushing it forward. So thanks so much for your time, Jonathan. It's been inspirational to talk to you, myself. And look, you're welcome to come back anytime and chat with us.
That's very kind of you. Thank you, Trevor. It's been a pleasure. And once again, thanks for inviting me. And it's been lovely chatting with you.
Hi, everyone. Thanks for watching. If you work in the mental health field, or you're a budding researcher in neuroscience, You might be interested in some of the other conversations I've had with other experts in the series. Please like, subscribe, and let us know what you think in the comments.